Hey, my name is Christoph Binkert. I'm working at the Kantonsspital Winterthur as an interventional radiologist, and I'm here in Valencia as SPC chairman of the scientific program. So for extensive liver surgery, it is very important to prepare the patient beforehand to have a large enough future liver remnant. Actually, the function may be more important than the size, but the size works as a surrogate for function. And so we want to do a preparation. Typically, this is done with portal vein embolization. The drawback of portal vein embolization is that you have to wait roughly about 6 weeks till you get enough growth of the future liver remnant before you can do the surgery. So the idea came up to do the embolization of the portal vein together with the hepatic vein embolization, and at the same session. And by doing this combined, you can increase the future liver remnant in a much shorter time. Typically, after 10 days to 14 days, you have enough growth of the future liver remnant to actually do surgery at that time. The technique of, you can call it double vein embolization or liver venous deprivation, is that you embolize the portal vein and the hepatic vein in the same session. If you do that, it is extremely important that you do the portal vein embolization first. Why is that? Because once you embolize the hepatic vein, you slow down the flow in the portal vein, which makes the portal vein embolization more difficult and more dangerous. So rule number one, embolize the portal vein first. Concerning the hepatic vein embolization, it is important that you have the knowledge about two different approaches. One is the typical TIPS-like approach, so you enter the jugular vein, go down with your catheter, and then select the right hepatic vein, maybe also accessory veins, and debatable also the middle hepatic vein, and then occlude them with blocks. The idea of that is that typically the hepatic vein is like a pipe system, so it wants to block the pipe system, then you can actually block the flow, and that is sufficient. Others really want to go a little bit a step further. In addition to the blocks, they also use glue to also embolize the collaterals between the hepatic veins, and therefore increasing the effect. The problem with that is it increases also the risk, because you place glue in a system where the glue can easily go to the right heart and potentially to the lungs. My personal view is it's not necessary, therefore I stick with the plugs only, and we call this kind of the double vein embolization, and others use additional to the plugs in the hepatic vein also glue, and they call it the liver venous deprivation. So these are slight differences, and right now we do not know if it's needed or not. Double vein embolization means to embolize the portal vein and the hepatic vein in one session. The goal for that is to increase the future liver remnant faster, which is beneficial for the patient because he doesn't have to wait that long for surgery.